So I'm going to discuss potentially how the use of oncolytic virus can really hopefully augment response and benefits of lung cancer and potentially other patients with solid malignancies. These are my disclosures. I want to start by really just, again, setting the scene in terms of the continued toll that lung cancer takes on public health. We'll talk about, of course, the immunotherapy revolution, some of the frustrations, and then that'll lead into some of the emerging data on some of these therapies we hope to utilize for increasing immunotherapy response. So as everyone knows, lung cancer is the leading malignant killer of both men and women. The 5-year survival rate of 18.6% is lower than many of the other leading cancer sites, such as colorectal at 64.5%, breast at 89.6%, and prostate at 98.2%. Even for localized disease, the 5-year survival rate for lung cancer is about 56%. We all know that only 16% of lung cancer cases are diagnosed at an early stage for a variety of reasons. And because of that, we end up dealing with a lot of significantly advanced lung cancer. One of the other concerns during this COVID epidemic, and which one of the earlier speakers had mentioned, is we know that there's a significant drop in cancer diagnoses since the pandemic began. And it's not that cancer is disappearing, but we're seeing about a 50% cut in the number of lung, breast, and colon cancer. And we're all concerned that that's going to lead to increased presentation of advanced disease probably in the next 6 to 9 months. And again, more than half of the patients with lung cancer die within 1 year of their diagnosis. So somewhat old slide, but it hasn't changed much. Lung cancer death rates are not the same everywhere. There's some disparities, as you see. There continues to be significant mortality in the South and in the kind of Mid-Eastern Atlantic states. It is a global problem, but it does affect people of different populations differently. Smoking rates have dropped, but they remain frustratingly plateaued in the prison population. People with mental illness, rural patients tend to have a higher smoking rate. So there remains significant work to be done. It is certainly true that not all patients with lung cancer are using tobacco. There's an increasing incidence of non-smokers. Nevertheless, we need to continue to work on not just screening, but smoking cessation. So a snapshot of just where we stand on lung cancer in 2020. As I mentioned, smoking rates have continued to drop, but stabilized. The use of e-cigs is contentious, and whether it really is something that allows tobacco users to get off combustible tobacco. I think the real concern among public health people is the use in teenagers and the explosion in middle school and high school vapors. We don't know long-term effects of what vaping is going to do over 15 to 20 years, and it's not clear how much of a safer alternative it is and whether it's a gateway to eventually transitioning to combustible tobacco. Lung cancer screening remains sadly underutilized. That was before COVID. It was estimated only about 4 to 5% of eligible people based on guidelines were getting lung cancer screening. So we need to do continued significant work in terms of getting the education out there and utilizing this approach. As you heard from Dr. Agarwal, genomic testing continues. It is improving, but it's lagging behind the NCCN current recommendations. And the more actionable mutations we have with tolerable drugs, this is very frustrating. And while the immunotherapy revolution has certainly changed lung cancer therapy, let's also recognize it is not the final answer, and there remain many people who do not respond to immunotherapy or respond and lose that response, and work remains to be done. This is a slide that's probably been seen in the majority of talks for the past 5 years. Just to remind you that we don't have infallible biomarkers for understanding response to immunotherapeutic drugs, but there clearly is some correlation between the number of coding somatic mutations and response rate to immune checkpoint drugs. So as you can see, towards the right, as the somatic mutation numbers go up, such as in cutaneous melanoma, skin cancer, where we're seeing really DNA damage from exogenous carcinogens leading to presumably new antigen formation, there are very robust responses to immunotherapy drugs. Down in the middle, you see lung cancer, head and neck, urothelial, and there are very meaningful and often durable responses here. But clearly, it's not solely a basis on mutation. And then all the way at the bottom of the graph, you'll see that uveal melanomas and pancreatic cancers have truly low response rates and profoundly low mutations. So part of the problem is figuring out how do we get some of these so-called cold tumors, ones that don't cause an immunogenic response in the immune system and presumably exclude cells, T cells, from their microenvironment. What do we do to aggravate that tumor or make it hot so that patients have better responses? So at least let me talk a little bit about the success that we've had. This was a recent article that looked at the initial cohort that was treated with nivolumab on a phase 1 trial, and it looked at patients with advanced melanoma and kidney cancer, which of course at the time made sense because we've always known that those are relatively immunogenic tumors that had responses to biologics. But there was a lung cancer arm, and this is where the activity was a bit surprising, gratifying, and this is the 5-year survival. And you can see that while the lung cancer survival is not that of the melanoma or kidney cancer patients, still, if before the immunotherapy revolution, I told you that 5 years out from starting on a drug, patients with metastatic non-small cell lung cancer, all of them heavily pretreated, would be alive, you would be fairly stunned and disbelieving. So while we will talk about a lot of work to improve those numbers, this is a substantial improvement that's been very gratifying. Also to show you, it's interesting, again, the lung cancer patients, as you can see, very low rate of complete response. These were all partial responses that led to stable disease for a long period of time. But nevertheless, despite that, it's been truly amazing to see patients 5 years out alive and doing well. And to go quickly over some of the data that really led to this paradigm shift in the management of lung cancer, this was a study that looked at giving the immune checkpoint drug pembrolizumab against standard platinum doublet chemotherapy in advanced lung cancer. And in this case, these were in patients all with PD-L1 staining levels on the tumor of greater than 50%, which is high. But if you're a patient, you don't get to choose if your PD-L1 level is high, and this is not a huge percentage of patients with advanced lung cancer. Nevertheless, you can see that pembro substantially improves overall survival as a monotherapy to the point that this has become standard of care. And while thoracic oncologists occasionally debate whether patients with high PD-L1, more than 50%, should they get chemo in addition to pembro, in reality and in practice, the majority of patients are more than happy, should they have a PD-L1 of more than 50%, to only take immune checkpoint drugs. And often, these responses are sustained for years. When pembro is added to chemotherapy versus chemo by itself, looking at patients with lower PD-L1 levels, we saw not as dramatic, but still a very substantial improvement in progression-free survival. When Dr. Langer presented this a number of years ago, there was some debate about whether we would see overall survival benefit. But with updating of the data, it was clear that we did. And so pembro plus a platinum doublet has become the standard of care now for patients with advanced non-small cell lung cancer, either with treated driver mutations or without driver mutations and without a high PD-L1. On the bottom of the slide, you can easily see that essentially everything is on the correct side of the line. Interestingly, the actual degree of PD-L1 was helpful, but at the end of the day, patients even with low PD-L1 benefited significantly from the addition of immune checkpoint drugs. Again, suggesting while PD-L1 is helpful, it certainly is not the world's most robust biomarker in selection of patient therapy. So is the glass half full, empty? And the bottom line remains, many lung cancer patients do not respond to immunotherapy. They all want it. It's not hard to imagine why patients really want to avoid cytotoxic chemotherapy. But at the end of the day, if it's not going to be effective, the question for us is, how do we identify who's going to be resistant or benefit, and how do we enhance improvements in survival and response? And this is where some of these adjuvant therapies, adding to immunotherapy, such as radiation and oncolytic viruses, come in. So why are some patients exhibiting primary resistance to immune checkpoint inhibitors? And there are a number of reasons. We think that in many cases there's an inadequate T-cell infiltration, mainly because the tumor is not that immunogenic. Again, whether that's because the mutational burden is low or other factors needs to be worked out. There's T-cell exclusion. There's tumor cell resistance to interferon. And there are other local immunosuppressive factors within the tumor microenvironment that's suppressing response to the body's immune system. Go back one slide. There we go. Mechanisms of acquired resistance, slightly different, but there's loss of T cells function, there's disruption of antigen presentation, and again, there's evolution of interferon resistance. So we're getting a better idea of the mechanisms leading to the development of resistance. So now the question is, again, how do we make a hot tumor microenvironment in those patients who don't have it? And there are a number of different strategies, as you can see on the slide, from metabolic reprogramming, modifications of the STING pathway, epigenetic reprogramming. We're going to focus on the cartoon part over on the right, looking at immunomodulatory factors such as oncolytic viruses or radiation therapy. So this is the Grateful Dead, and as I get older and older, I realize fewer people in the audience will have any clue what I'm talking about. So the Grateful Dead were an American psychedelic rock band that came out of San Francisco in the late 1960s. I'm going to try to explain what this has to do with oncolytic viruses. So they were a huge force in American music, and they developed a tremendous cult following. And then when Jerry Garcia, their guitarist, died in the 90s, they splintered up. And yet there are still fairly rabid fans out there who, 25 years out from the end of the band, continue to really appreciate their music. And you might say, well, what does that have to do with anything? So recently Nike decided to launch these Grateful Dead-themed sneakers. And you might think they're aesthetically displeasing, as my wife did, but nevertheless, you would think, why, from this band that has really not been functional since the mid-90s, would people get excited? And that's not an unreasonable question, but the website crashed and people were unable to buy it the day that they offered. And you can go to other websites that are selling sneakers secondhand, and you would probably be horrified to see that these sneakers are now going for $5,800 a pair. And this is kind of like the trajectory of oncolytic viruses, because in the 60s and 70s, there was a lot of interest, and they were able to cause local responses, but we didn't really have systemic therapies, such as immune checkpoint drugs, that were useful. But we do now. So again, I think that there are a number of approaches that you'll see being taken in the clinic. So one approach, obviously, is to add a number of immunotherapeutic drugs together in combinations. There are a lot of on and off switches on T cells, and you can look at drugs that block the off switch or turn on the on switch. And this is a very attractive possibility, but toxicity does go up once you start combining immunotherapeutic drugs, and cost really starts to go up. And certainly It goes up with all of these things, but I think that we have to always keep in mind what the cost of these drugs are and how is the medical system going to be able to make sure benefits get to patients while we're not breaking the bank. Other options, addition of radiation therapy, and we'll go over that, addition of oncolytic viruses and the rationale behind it, we'll discuss that, and then tumor vaccines, which we won't really discuss today. So just to remind you what oncolytic viruses do as a class. So they tend to be taken up preferentially by tumor cells, much more than healthy cells. And sometimes these oncolytic viruses are just modified so they don't really replicate. Sometimes you can put interesting genes into the oncolytic virus so that it's taken up by the tumor cell and produced, and it can make things like GM-CSF. And then as tumor cells pretty much die and explode, it is that it causes effects in the tumor microenvironment with cytokine release. You get induction of T-cell mediated anti-tumor immunity, and then hopefully you get regression, not just where the oncolytic virus is injected, but hopefully systemic, and we'll look at some of that data. There's a whole cascade that gets triggered when the virus is taken up, releasing things like PAMPs and DAMPs and other cytokines, and it does add to this whole kind of milieu where hopefully antigen-presenting cells are able to better present tumor antigens to T cells for response systemically. So let me talk a bit about where we stand with the addition of radiation to immune checkpoint drugs and where that's gotten us so far. So when the medical oncologist first saw immunotherapy, it was pretty exciting. We finally had a new class of drugs to use, and the radiation therapists were a bit sad because they felt jilted, and we had often used chemoradiation for a variety of tumors. And so there was a hunt on to see how radiation could, I guess, get back in our good graces. And there is rationale for this, right? So the abscopal effect was noticed many years ago in the 1950s, where when you radiated a tumor site, that in a non-radiated field, you would see response. And it was rare, and it had been rarely seen over the years, but the idea is that, again, as radiation kills cancer cells, you get cellular damage that elicits cytokine release, inflammatory mediators, more presentation of tumor antigens to the immune system, and in fact, it acts like an almost kind of in situ vaccine. And so that has been the idea to say, well, maybe we can use this to enhance response, especially in cold tumors, to immunotherapy. I will point out initially the abscopal effect was where you gave radiation and no systemic therapy, and you had a distant response. It's slightly different than it's used now, because now we're talking about giving an active systemic therapy. The difference is now we're talking about increasing the incidence of response when radiation is given. And so the question is, do we have data that this does stuff? And some stuff is coming that's looking very interesting. I will say that we know that radiation often can affect DDR or DNA damage response genes. This is an interesting paper that came out recently that essentially showed that in patients with mutations in those category of genes, in DDR positive, that the response rate to immune checkpoint drugs was higher, that the progression-free survival was better, and so that is interesting, and maybe not only is this a new biomarker that can help us as part of the puzzle of who's going to respond, but it might also allow us to exploit damage to those genes. I will also show in the same data set, they looked at patients with high PD-L1 greater than 50%, a group that we knew already did better with immune checkpoint. And you could again see that even if the PD-L1 is high, DDR is an independent marker of suggesting responsiveness to immune checkpoint drugs with a response rate of over 50%. But we've already seen this in real life, in real people, and this was the Pacific trial that really completely changed the management of locally advanced lung cancer. This was a trial that looked at patients treated with chemoradiation. They were randomized afterwards to placebo or durvalumab, an immune checkpoint drug. And you can see that as those patients were followed, there was a substantial progression-free survival advantage in the arm that got durva at 18 months, 44% to 27%, and follow-up data has confirmed a overall survival advantage. So this quickly has become standard of care now for locally advanced lung cancer, which has traditionally been a very difficult to treat stage of disease. You'll see that when they looked at the prognostic factors, most of the important stuff was on, again, the correct side of the line. It didn't really matter if they were squamous or non-squamous. Curiously, whether the PD-L1 was above or below 25%, there was some variation, but not super strong. Both groups responded. Importantly, in this data, you'll see that when the last radiation, the randomization to durva or placebo was within 14 days, you'll see that there was a significant improvement favoring durva. Now, that might mean one of two things. It either means that patients who can go on to durva quickly after finishing chemoradiation because they tolerated it better because of other factors are more likely to do better anyway, or it means that there was some residual effect of the radiation, and by starting durva sooner, you are getting a better synergistic reaction. And I suspect it's the latter. And so in this case, we try to get our patients onto durvalumab as quickly as possible after the completion of chemoradiation. Now, it has been used in metastatic disease. This was a paper from Thielen et al. That was in JAMA Onc last year that looked at patients given pembrolizumab, and then some got SBRT. You'll see it's not, at the end of the day, it was not a huge trial. It was a phase 2 that looked at 40 versus 36. This was not a positive trial statistically. There is a trend of benefit in the experimental arm. You'll see that everything's bouncing over the one at the hazard ratio. But there was some interesting stuff to tease out. And the important thing on this table is if you look at the control arm versus the experimental arm being the group that got SBRT plus pembro, that in PD-L1 greater than 50%, not shockingly, both groups did well because we expect those patients to do well. But in the PD-L1 of 0, you can see that the experimental arm, and I know we're dealing with tiny numbers, but nevertheless, there is maybe an inkling that the experimental arm did better because of radiation and SBRT causing a cold tumor to be hotter. And this is something that we need to continue to look at. Luke et al. Also looked at multi-site SBRT in patients given pembro. This was really more for toxicity, looking at a number of sites in patients with a number of histologies and solid tumors. There was some interesting data. It was definitely safe. Encouragingly, there was not increased toxicity with the addition of SBRT to pembro. But again, while we're looking for something a little more dramatic, there certainly was not worse outcome. There certainly was not worsening toxicity. Now we get to what hopefully oncolytic viruses can add to the immune checkpoint story. There are a number of ways, as I had mentioned, to utilize oncolytic viruses. So one way is to use a viral vector to essentially transduce genes into tumor cells. And at Houston Methodist, we've been using an HSV-TK for many years, but the idea is that in this adenoviral vector that's taken up by tumor cells selectively, it incorporates HSV-TK. You then give the patient ganciclovir, and as HSV-TK works on that, you get compounds that essentially are toxic to dividing cells. So you exploit differentially tumor cells versus normal cells, and then you're able to cause DNA damage. And it's been used for about 20 years, including data in prostate cancer. And the important thing, essentially, that you're seeing on this slide is in rat model, at the bottom line, you'll see this is a combination of radiation and the HSV-TK, giving by far the slowest growth and the fastest response. And you'll also see that they had by far the longest survival. So it clearly looked that giving an HSV-TK into a tumor and then giving radiation synergistically was able to cause tumor death. And when they looked at and were able to biopsy it, again, you'll see the line all the way on the right, on the bar graph, the combination of HSV-TK with radiation led to, by far, the most infiltration of CD4 cells into the tumor, supporting the idea that it's able to mobilize the immune system. This was a study that looked at different adenoviral oncolytic viruses, although the concept was the same. They either got radiation, they got the virus, or they got both. And in the circle line on the bottom, you can see that the combination of oncolytic virus plus radiation substantially kept tumor growth down, as opposed to either radiation by itself or essentially nothing. So we know that there's a synergy here that's very interesting. So now moving on to some recent trials that have been encouraging. This was a trial that was published in Science Translational Medicine earlier this year that looked at transducing an IL-7, IL-12 into tumors. And you can see that it's given into mice. They get the virus, and then they're given anti-PD-1 or anti-CTLA-4. And clearly, mice who got the injected oncolytic virus with this IL-12 and IL-7 did substantially better, and there was clear synergy. When they looked at the pathology, again, similar to what we've seen before, an increased infiltration of immune cells into the tumor microenvironment, enhanced MHC class II expression on antigen-presenting cells, upregulating multiple immune pathways, inducing, encouragingly, regression of tumors in non-injected distant tumors, upregulation of PD-L1, again, not just on the injected cancer cells, but in distant tumors, and importantly, no symptoms of a cytokine storm. This was a trial that also looked at neoadjuvant oncolytic virotherapy, but this was given before surgery. So this was in a model of triple-negative breast cancer, and you can see that they got the virus, the tumor was resected, they were then re-implanted with tumor and were given immune checkpoints. And you can basically see that in patients who got the viral injections and then got challenged with the immune checkpoint, they had a substantial improvement in survival that was dramatically better. So here's a case again of an oncolytic virotherapy in the tumor immune microenvironment, sensitizing the immune system, so even down the road, improved responses. And you might say, well, that's great. I know, it's mice. What have you done in people? So this was an interesting trial that was done also recently. It was done, however, in patients with pancreatic cancer, which I'd shown you is a very poorly responsive tumor, pretty much to everything, cytotoxics as well as immune therapy. And this utilized reovirus, oncolytic virus, the pelareorep, with pembro and various chemotherapies. These were in patients with metastatic pancreatic cancer who had already progressed on frontline therapy. And I can tell you that generally they do just horribly. The important thing here is that when patients got the immune checkpoint drug, in addition to chemo and the oncolytic virus, there were 3 patients who had pretty substantial responses. So while that's not like a home run, it does show that in a very difficult to treat tumor that tends to be very cold, it's possible that we can exploit oncolytic virus and immunotherapy to better improve responses. And other trials are underway to confirm this. In that trial, you can see at the bottom that in the post-treatment, increased CD8, increased PD-L1 expression. So this is, again, more proof of principle. This was a novel study that really didn't look at anything too fancy in certain ways, but it looked at the seasonal influenza vaccine. And what they found was that when they gave the flu vaccine injected into the tumor, mice did better. So on the right, you'll see that when you give the flu vaccine and PD-L1, you had dramatic responses systemically, not just into where the flu vaccine was injected, and it was sustained. And that was a much greater response than to the flu vaccine or to PD-L1 by itself. And it also, by the way, worked in mice who had been resistant to immune checkpoints. In the center, you'll see pie charts. The important thing is on the bottom, the two pies on the bottom show that when you give the flu vaccine and they look at dendritic cell, you see dendritic cell expansion and T cell expansion. And so, again, the attractive thing here is that this really shows further benefit. This is something that already we have available and theoretically could be used fairly quickly to act to stimulate the tumor microenvironment. There's been other studies showing similar interactions. This was a study that looked at TVEC, which is an approved oncolytic herpes virus that makes GM-CSF that we use in melanoma. And this was looking at a combination of TVEC and ipilimumab. And you can see that the patients first got TVEC, and then after about 6 weeks, they got put on IPI. And you can see that a substantial improvement in CD8 count after IPI and also in CD4 with corresponding improvements in responses. And so there was clearly a synergistic response in this trial where patients who got IPI and TVEC did better than either alone. You can see these were in heavily pretreated melanoma patients, and you can see the waterfall plots showing some nice responses. And as always, so gratifying, a number of patients with substantial ongoing responses at 24 months. Granted, it's melanoma and it's an immune-sensitive tumor, but still the combination responses are gratifying. So all of this work led to us opening the STOMP trial here. This looked at patients with non-small cell lung cancer and triple-negative breast cancer. We've just enrolled our final patients, so we look forward to sharing the data down the road. But just to give you an idea of what the trial, these were either triple-negative breast cancer patients who had stage 4 disease, that either failed one or more lines of therapy, or immunotherapy naive patients with advanced non-small cell lung cancer who were EGFR ALK negative or had been treated already, or they could have had one regimen of immunotherapy. They get adenoviral HSV-TK followed by valcyclovir for 14 days. They then get 5 treatments of SBRT over 2 weeks, and then they go on to Pembro. And we'll be using the immune assessment core here at the Houston Methodist Research Institute, where we'll be able to do mass cytometry with fluorescence cytometry, where we can get just amazing details of multiple populations of immune cells that you can see on the right. That kind of looks like something the Hubble telescope takes, but instead that's all just data looking at whole different categories and classifications of immune cells. And it'll be fascinating. You can see some of the data that we'll be able to generate looking at T-cell populations before and after SBRT and HSV-TK, and then we'll be able to correlate that with response or lack thereof. And just to show one case, this is our first lung cancer patient who went on to the trial. It was a female with adenocarcinoma. You can see on the PET she had a large right hilar mass that was bulky and hot. She also had adrenal metastasis. She did not have any driver mutations. You can see that the PD-L1 is 20%. So while not necessarily high enough for Pembro single agent, you might have predicted that she would do well, but she did really well. She went into a complete remission, and now at 2.5 years later is continued, is off therapy, remains free of disease. Hopefully we're going to see more and more stories like that as we get more data, and we'll share as it becomes available. So our hope is down the road that the utilization of these oncolytic viruses to modify the immune microenvironment and turn these tumor hot will allow radiation therapists and oncologists to continue to be best friends as we continue to try to expand the benefit of immunotherapy for our patients. And that's what we're all hoping for. Thank you very much.